We have a few observers today, which is great. Many members of the staff that are on development programmes. Emma Finley, Associate Director of Clinical Governance and Quality Assurance. Emma, thank you for joining us. She's participating in the Aspiring Nurse Directors Programme, so it's wonderful to see you here. And Sarah Sturner and Becky Berry are both business managers doing the development programme as well. And can I welcome Georgia Denegri? Georgia, you're most welcome. Interim Head of Corporate Governance, working with the bill, who's taken over from Jill. And Jill, you've been with us as an interim for about a year now and worked really hard. Thank you for all your efforts and your work. Thank you very much indeed. And we've got a few board members attending via Teams, and we're ready to kick off. I think just wanted to set the scene really. Today we're going to be focusing, as we always do. I think I would say four main areas, and it's around patient flow, staff culture, and staff survey, and quality and finance. And we've been externally scrutinised, quite rightly, and regulated, and will continue to be so. And when you are externally regulated and scrutinised, it's important you pick up on the things that you need to improve on. And the areas, the 3 or 4 main areas we're looking at is our patient flow experience. More about that, much more about that in the meeting continues, the staff culture and staff survey, and the quality and finance. You'll see the big theme of Jane's report is around patient flow, because that's very important. At the very basics, it's we've just had, for those that have just joined us, we've just had a patient story, and the lessons from the patient story we need to hear, and they are real, and we need to improve on. So that's sort of setting the scene. I've got some apologies. I haven't got any apologies actually, so that's great. Declarations of interest. Are there any that's not registered up on the internet? I'm not expecting any. We are great. And please, the meeting's been recorded and will be published on the website, as always. Just speak loudly as you can, so we can get the microphones all over the place, just so we can pick everything up. Minutes, I do need to approve the minutes of the Board of Directors meeting held on the 2nd of October, and actions and matters are so I seek approval of the minutes as an accurate record. And the action log reflect close. Yeah, the actions are closed. Questions from members of the public. We have a list of detailed questions from a member of the public, which we received, have received. So we will obviously work on those and look into it and get all the answers. And what we'll do is obviously report back to the member of the public who's asked the questions, but we will provide a summary at the next board meeting in February as to how we've actioned them here. I think it's probably the best way to approach that, and thank you for the questions. I think the way we'll do the chair's report and the chief executive's report is how we've done it in previous. I'll set the scene and then over to Jane. I think just to provide a few points from my report. The Positive Practice Awards, which we have just had, just really want to acknowledge that we had them. They're absolutely fantastic. They're a great part of the year. Thank you for those that got partnership arrangements with sponsors. It just made life a bit easier for us. And during the year for us, it was really well attended, nearly 400 people, and thank you for the board directors and the governors that came and participated. It's a really fabulous part of the event. We do concentrate on board meetings about the areas we need to improve on, but we never forget the incredible achievements of staff and the hard work that goes behind people really succeeding. Also to say that the few things that we can control fairly quickly regarding our national oversight framework scoring. One of it is the staff survey, staff culture. The staff culture will take time. We have a very credible plan to change our staff culture, improve our staff culture, as we've just heard. But one thing we could do fairly quickly is to improve the rate of our kidney star survey completion. And as always, I believe for this organisation, when we identify an area where we need to improve on, and you put your energies and focus into it, we succeed. And in the end, it was a 57.4 rate, which might improve. That's the best rate we've had. It exceeds the national average. It exceeds our stretch targets. So it is very good. Obviously, the content of it, the next stage will be when we get the interim results from it, how we action those and quickly learn by it and make some amendments. But the only thing we can do at this stage is to get the rate up, which we have done. And a particular thank you to Funmi, Dan, and others, all of you. You've been working hard to do that. On the finance, I don't really need to say too much. We will be going into the details of finance during the board meeting. We are predicting, we are forecasting the break-even this year and working very hard on next year's budget now. I wanted to say that the ICB chair, I mentioned the Integrated Care Board and the new chair, Ian Smith, who came to our Council of Governors, he's run out to see our services. It's quite impressive, given that he's just been appointed. He wants to go to see some more services over the next couple of months. He's very supportive of mental health services, very supportive of community, local authorities in particular, and local authorities leaning into our agenda, and will be useful from our perspective. But I think I have to say that the amount of pressure we're under as a system at the moment, or as a service, as a trust, it has impacts across the system. And our relationships are really important. From time to time, our relationships can get strained with all the pressures because we want to do the best for our patients. So we work with the acute trust and the community and primary care. And again, thank you to the execs who are working really hard to maintain those relationships, because without that, patients start falling through the net and don't get a good experience. And then finally, we've got we've got the National Oversight Framework, we've got our capability assurance framework, rating ourselves how capable we are, and then our forward assurance framework, the BAF that we call it. It's a really important document, and we will see that's on the agenda, but also how that relates to our priorities of patient flow and quality and finance. So that's it for me. Jane, and then we can turn it open.
Thank you. Hi everyone. So I have to apologise. I'm going to keep my talking to a minimum today because of laryngitis. I start coughing as soon as I talk. So apologies that I'm not as talkative as normal. But I was going to talk a paper on the 12-hour breaches when I was first thinking about what I was going to talk about. Those that are waiting over 12 hours for admissions. But as I talked about it and thought about it, it really was about flow. It was about the whole journey, it all interplayed. And I was thinking we need to think of it as a whole rather than separate bits, because one impacts the other so significantly. And you will see from the reports that we have challenges, but we have a plan and we have made progress. But we need to make progress at more pace than we are now. And I'm very fortunate to have Oliver leading on the 12-hour breaches and John leading on the length of stay work. So they'll be able to answer some questions as well, but I'll open it up to questions rather than talk in any more detail.
And yeah, that's good. Well, you stuck to that plan. And just to complete, we have been through the process of appointing a senior independent director, Cathy Winfield, nominated. Went through the Council of Governors. We need to formally approve Cathy Winfield as our non-executive director, who's our now senior independent director. Thank you very much. Okay, yes, phone open. Dan.
Just one point that relates both to your point about culture and patient flow. I'll channel my inner Funmi here, and by saying that the NHS Star Survey is one really important measure of culture. It's one measure. What runs alongside our focus on the survey is that ongoing focus on leadership, communications and engagement, empowering staff and empowering teams and giving them agency. And I think it's that last point that really speaks to the work we're doing for patient flow.
I should have picked it up earlier in the minutes of the last meeting. Jane had raised the question at that point about electronic patient records, that there were some teething problems. Is that still going on, or has that been sorted?
I can answer. We had the EPR programme board yesterday to review. The issue we had was migrating data from your system. I've had to create a special so we're on course now. It's a robot doing it, believe it or not. So sorry?
Based in China?
No. So they were able to run a test with the entire data set and
Thank you.
You know, just talking about James, I'm just really pleased with some of the stuff that we're seeing coming through, you know, with some of the processes that we're going, you know, through. I love all the stuff about the neighbourhood teams, the mental health team. That really is part of what the NHS is trying to do. We're trying to get into more sort of integrated care, community care. And I think what I wanted to say is that just to ask everyone to recognise that it takes time for these things and that we need to exercise patience. You know, if you think that if we're going to have the neighbourhood teams, we are going to actually, that might mean in the short term we may get more people coming in because the neighbourhood teams are working, so more people are going to access our services. So we may actually see the numbers almost go the wrong way, quote unquote. And so and then it takes a while for these relationships between different partners to work. From the voluntary sector, we know it's been really difficult to get in, with the NHS, speaking different languages, and so for this to be successful, those who've been in the NHS for a long time would say that there's always been iterations of this sort of neighbourhood community working thing. So if we don't want a failed sort of system, we have to recognise that we need the time to build the relationships with our different partners so that this actually is really embedded and it works. I like the fact that in the report it's saying that this isn't just about hospital beds and getting people in and out, because I think it would be really the wrong message if people are hearing that we just need to make sure that we meet these targets, because it's also got to be about the experience of the patients we've just heard. And I think working in this way gives us that opportunity to really meet people holistically. And to realise that they're not just a number, they're not just a statistic or someone with symptoms, they're someone a parent who works, who was a nuclear engineer or whatever they were. And so I'm really pleased with the direction that we're taking, but just to remind all of us that it does take time.
It does take time, and it's always a balance with this complicated programme. We need to make it equal. I'm just thinking, Jane to my side, what Jane will get was, great programme, but she'll get from patient groups, she'll get from the ICB and regulators, but you need to do it quicker. So it is just, and we need to ensure, it's balance, and we need to ensure we give support to the clinical leaders, etc., to make that progress with the right amount of pace. So it's John and Anil.
Thanks. I was just going to reflect on the paper generally. So I think it's really, the point you make about time, I think is very valid in terms of the length of time that some of these challenges have had. But I think it's important to just remind ourselves that there's a significant patient safety issue at the heart of this. People can't come into hospital in as quickly as we would like them to do so. And that needs to remain our key focus. However, I do think it is also really important to just look at the scale of transformation and change that we've achieved over the last 3 years. So whilst we very much focus on inpatient services, length of stay, if you look at the developments around housing, you look at the impact and the numbers of people going through our staying well services, our rapid response services. That's very different. That's very different from 3 years ago. That is in no way to appear defensive and suggest that we do not have a considerable challenge. We do. But that's a very different picture. And many of those services are delivered in partnership with other agencies. So if I think about our strategic objectives around working in partnership, that is different. I even wrote down myself length of time because I do think that's really important. I think the other thing I'd be keen to get across is the level of clinical engagement in this challenge feels different. Working with Oliver and David, but it does, as someone who's been around this for a considerable period of time, the level of senior medical and senior clinician of all flavours involvement is different. And I think we're starting to see a step change in the level of understanding and buy-in to resolving this.
A comment and then a query, if I could, just amplifying Abiola's point. John and I were able to visit Linwood on Monday this week. I must say that Unity, Abigail and so many others lead that service with great aplomb. Neighbourhood mental health teams, one thing that did arise on the back of what Abiola says is that with extremely heavy caseloads, we need to afford the opportunity to, not just Abigail, Unity, but others, the time to engage with system partners, if indeed those neighbourhood mental health teams are going to deliver what we hope. The question, and forgive me, I may be conflating two things here, Jane, that are not natural bedfellows, but you talk about, we know, and you refer to Chalk Hill, the issues there, and indeed, perhaps reasonably put, some of the delays in dealing with that reality. And we now know that Morehouse, as external consultants, have been brought in. My question is that in terms of the efficacy, using Chalk Hill as a backdrop, the efficacy behind bringing Morehouse in, does that evidence an expertise deficit that we need to fill over the longer term or not?
Yes, ma'am. That's why we are looking hard to this. What they're being able to do is, I'd say, turbocharge what we are planning to do longer term. But we haven't got the continuous quality improvement skills within the trust at the moment. That's the work we're doing in the more medium and long term. But I didn't want to delay this piece of work, so we brought Morehouse in to support us at the front.
Very good question. Let's take Cathy and then from Cathy, please.
Hi. The sound quality isn't brilliant, so I apologise if I'm touching on something that Oliver was talking about. And that was really just to absolutely recognise the innovation and the innovation in new services, and also the work around reducing the time that people are clinically fit for discharge. But one of the interesting things for me was that overall our length of stay is longer, even though that clinically ready for discharge bit is shorter. So that says to me there's something about the clinical decision making and people perhaps being more cautious about deciding that somebody is fit for discharge. And so for me, there was something about, is there something about thinking about that clinical decision making, the confidence our clinicians have got to make that decision, and their understanding of the sort of new ecosystem of services that's out there, and their confidence to sort of lean on those services and refer people through. And my second question was also about the extent to which the rest of the system supports us in routing people to the non-admitted options away from ED. And I know we've got the blue light triage, but if somebody actually presents themselves to ED, do ED staff know to say, actually, you can go to A, B and C instead? So it's the extent to which we've got the clinical decision-making confidence, and the extent to which the rest of the system is supporting us in routing patients into the right place.
Great questions, Cathy, and we'll ask Oliver to address certainly the clinical decision making. But just on the rest of the system, we could always do with better. We could always do better. We could always do with a better response to the rest of the system. I think I would pick out local authorities. You know, they're under so much financial pressure, but a lot of things that sometimes they have to cut is services that help mental health, learning disabilities, and it has an impact. But I must say, our relationships at the local level is pretty good with local authorities. So that has to be stressed. Yeah.
So just to say, Kathy, I think we are beginning to see an improvement in the length of stay, and the number of patients waiting for more than 60 days has shown a modest reduction recently. There are three. I also want to respond to Neil's question as well at the same time. There are effectively three areas we might think about in terms of our first service design. So if we don't want patients to go to A&E, we need to give them a meaningful alternative. So that's why we have our Staying Well service, and it's been very successful, and we need to get behind that success and reinforce it. That's just an example, but there are others like John mentioned in the response. We've seen 50% reduction in our Section 136s. It's also about the culture, and in particular, the experience that some clinicians have of being blamed when an unfortunate incident occurs. So the patient safety incident response framework is really important in terms of really moving away from a blame culture to a learning culture. We also hosted the Big Mac in September, where we had the coroner come and speak. And again, that's about trying to help people feel that whilst we have to respond to incidents and give a clear account of the work we have and haven't done, and where there's learning to be done, at the same time, we do not want our staff to feel unduly blamed, because that will promote defensive and harmful practices. Just as you described, holding on to patients for too long when actually we need to get them home. And then the other thing I want to really stress, though, is the importance of leadership. And so we have spent the last year or so really focusing on our clinical leaders in the organisation. So the whole move to the divisional structure was in part to create the triumvirs. And we've made really great strides in stabilising our clinical directors. We've just appointed substantively to our specialist division clinical director, for instance, but also our lead psychiatrist. And a couple of years ago, when I first came to the organisation, about 6 out of 16 of those positions were filled, and they had been vacant for very long periods of time. And this meant that our psychiatrists weren't effectively supported in doing their roles. And at the moment, we only have one vacancy across the organisation, so we have 15 out of 16 filled. We cannot do the changes without those people in place, having the structures they need to do their job. And we would not really be able to make use of an organisation like Morehouse if we didn't have those people in place. So Morehouse's job is to get alongside those people and to give them resource in order that clinical directors in particular can lead and direct, and Morehouse is there really as a primer. It's not really to replace them, it's to assist them in doing that job. But we could not do that if we didn't have those leaders in place.
Great. I mean, really good responses. So we've got 4 wanted to come in. I'm conscious of time, but if we take Lynn's point, because that would be a challenge from the non-exec, and then there's fully John and Dan, and you can help give the sort of wrap up the response from the executives. Lynn.
I was just listening to everybody and thinking, particularly John, opportunities for people to get involved in boards and in services and etc. The great skills we have out there. And I was thinking about the institutions. And the institutions ran within us and then kind of philosophies. There's staff and patients and a very different level of authority or opportunity. And what we run today are significantly different services. But that means that what we need is a constant churn of people coming through our services who want to work here, but also a training in a very different way. Being coached in a different way and being led in a different way. And I just wonder, we might want to just stop and think about, have we got all of that lined up behind these great ambitions that we want?
Good. Well, great place to start with funding.
Thank you. So I just wanted to build on, and I will build on some of the things that Lynn has said, but to build on what John, Oliver and Neil has said. So when we think about what we've all been talking about this morning. It centers around the need for a service redesign and that answers the questions that we needed to answer. We've talked about culture, both from the point of view of a culture of learning. We've heard that from our speakers this morning, but also the culture around the blame. We've talked about capability. Do people have the right skills and competencies to actually deliver what it is we need to deliver in the new service redesign? And do we have the capacity to then do that? And just reflecting on all of that, because I think what you'll hear from all of us in different measures is that we have a plan, or we're doing, or we've improved. But I was thinking about the journey and how many of us have a shared language and knowledge around that journey, knowing that should we or could we take the advantage of doing more around showcasing continuously, this is where we started and this is where we're going. And what that does is it helps that point in time, because what often happens is we look at the point in time and we go, this isn't right. But if we're able to understand the point in time in the context of where we started and where we're going, it helps us collectively as a board have that shared knowledge, but also do better in that top-down, but also that bottom-up bits for the new people coming on board into our organization. And then that really does help us to really channel our CQI journey in a more targeted way. So I just wanted to reflect on that.
And look forward to more plans and about that, constantly reminding people about the journey we've taken and as a result, because we probably don't do that enough. Thank you for me. John.
It was just in response to Kathy's question around system partners and the involvement of system partners, particularly in offering patients an alternative. I think if patients arrive in an emergency department, I suspect they're less likely to be offered an alternative, partly because actually if you present to an ED, then they feel that they have a sort of a clinical governance process that needs to be followed to assess them. However, all of our liaison teams are very live to supporting patients to be discharged or redirected to other services. So we know 30% of patients that come to our havens directly transferred from EDs. The number of people that go to staying well services come from EDs. In fact, actually, we've just been working over the last couple of weeks to arrange an in-reach support from our staying well service in Brighton and Hove into ED. But we do have some really positive relationships with CCAM. So CCAM do convey people directly to the havens, and they contact the blue light line and they support patients to be seen by the rapid response service. So we are trying to narrow the angles. But I have some sympathy for the acute trusts. If I present it to ED, they will feel that there is a responsibility to assess me in the first instance.
Very much.
That sounds very positive, though. Thank you.
And finally, Dan.
Another one, just to your point, Kathy, over the last 18 months or so, we've been leading a system piece of work on mental health crisis care signposting and involving people with lived experience. It's actually the first time in Sussex we've got a clear, consistent description across VCSE, local authorities and NHS about where people should go in a mental health crisis. Much more work to do, but it is good progress, and we did see an improvement in last year's patient survey in people reporting knowing where to get help in a crisis.
Okay, thank you very much indeed, everybody. The Board Assurance Framework, live document, we've part of a board development workshop on it fairly recently. And we have now got Nabil, who's well established, to be able to take us through that.
Thank you, Chair. Nabil Jamshed, Director of Corporate Governance. I think I would like to do 2 or 3 things. Firstly, from the outset, I'd like to thank every one of you around this table for helping us to shape it in the way it has shaped along the journey of making it a live document that we can use, apply in our day-to-day working. So really big thanks to all of you, firstly. The second thing I want to do is I want to draw out some key themes that take the report being read. And the last thing I want to do is orientate ourselves to a new way of presenting the Board Assurance Framework, if that's okay. So in terms of setting the context and the key themes that I want to bring out, I think it's really important to acknowledge that our Board Assurance Framework recognises, firstly, the complex external environment that we are operating under as an organisation. lot of pressures coming from left, right, and centre, and it reflects and acts to those in a way that it is live and responds to them in live environment as we go through. It really draws out some really strong interdependencies between our operational work that we do, our strategy as an organisation we hold on to, and all areas of operations. I call them license to operate in my own language, but they are really around our workforce sustainability, for example. How do we embark upon our digital journey? How do we look at workforce sustainability? How we look at operational pressures? So they're not looked at in isolation, they're looked at in an interdependent way. And I think that's what our BAF is doing currently. Of course, more work is needed on that front, but that's where it's heading. In terms of the strategic drivers, it talks about the consistency controls that we have on the framework, which I think allows us to focus and narrow down our attention to say we recognise that we have risk in the delivery strategy. However, we do have controls in place, and following those controls, we have actions in place that further bring risk down to the outline of it. When we look at the assurance and control maturity, which is a really important function of our board assurance framework, I think it's really, again, very helpful to recognise all the committee chairs have fantastically and brilliantly led the discussion at the committee level, seeking that assurance on behalf of the board around the risks that are in relevant areas. The quality committee would have received their own cut of the risk in a more detailed way, people committee, and so on and so forth, and finance committee, which has been a quite helpful journey. What it does do, it draws out a specific assurance profile as an organisation. And when we look at that profile and what we're dealing with currently, I think it's not by any magic, it is purposefully linked. So when we look at our risk on the back, they are talking about our capability, leadership skills, it's talking about our capacity, which is all around patient flow, it is talking about our quality improvement journey, it's talking about our sustainability, and most importantly, he talks about the quality in its comprehensive way, which is all around the patient safety elements, quality elements, and patient effectiveness elements, and patient feedback. So it is comprehensive in that way that it touches on all elements of the key business that we do. I think that the one last thing I want to say about this section is about the relationship that we're trying to build between the board assurance framework and corporate risk register. Now, in this organisation, we have a very detailed and comprehensive corporate risk register, and following that, a risk register. The aim here is that we are, when we see it next time, it will be more closely linked to corporate risk. It will allow us to drill down onto the significant risks that the organisation holds and how they relate or impact on the board assurance framework risk in positive or negative way, and what does it mean to us. So that will be drawn out as we go through the iterations of that. I think one thing I would want to acknowledge is when you look at the report and the body of the report, there is a table in there that talks about our key risks and the profiling of them in terms of our current score and future score. And the assurances, when you look at our key controls, are minimal to partial in most areas. And those are reflected in the score. The point here is for the board to note really is to think about this is our starting point, henceforth the risk scoring is slightly higher. As we go through the journey, the intent is that will come down. If it doesn't come down, at which point we will need to worry, because that work is done at the committee level. They do that work, see that assurance, and ensure we are working our way through to ride these risks down, mitigate those actions, and bring those risks down to a safer place within our risk appetite. That's what I wanted to say from the outset. I think it's really important to acknowledge the new template we have created. I'd like to spend just a quick few minutes on that. So if you look at Appendix 1, the first page gives the grants of guidance how to use the board assurance framework. Again, there are more improvements to do, but this is our starting point and we'll improve as we go. The dashboard gives us one snapshot of the organisation, where we are holding our risk profile. At the moment, as I said earlier, it is all around red and amber areas, and that is because this is our starting point. The BAF, this is the first time we're seeing the BAF of this year, and it will continue. The point again from our development work that we've done throughout up till now, And we are going to link the BAF to the cycle of the strategy, not enabling that. So it's long-term thinking, it's strategic, it's more focused around that. The next page gives us kind of the dashboard that talks about how does it all interlink with the work that we're doing. It talks about the ambitions and classifications with our residual risk, which is at the top of page 3 of the appendix. It talks about how risk reflects and how the triangulation is illustrated. Again, when we look at our board assurance framework, all the risks from 002 onwards to 0010, they all are interlinked. So you will find a quality element of risk in a finance risk or a people risk or vice versa. It is very interconnected. But I think what this shows is how they all interlink with the triangulation happens, which I think is an important feature. The next bit talks about how the committees of the board and the board in itself holds the risk and the profiling of that, which is an important feature. Following on from that, the last page that I want to draw onto is really talking about the overview scores, which is provided into a dashboard format. It gives us radar information that talks about our journey from inherent risk, where we start the risk, to this journey through where it is currently as our residual risk, and where it's heading as a target risk. So you will see an intention, a kind of a journey that shows our trajectory from where we start from red, where we currently are as red amber, moving towards more amber yellow areas. That's the intention over the course of the period, and that's where we would like to see the movement. If it is not happening in that way, we will hold ourselves to account and ensure that happens. That's the key metric that we will need as a board for us to hold us to account. And the other pages are the details of the risk, which I won't go into the details of. They have been scrutinized at the board. One thing I think for this board to, in the public meeting, to acknowledge and note for minutes purposes is, at the workshop on the 6th of November, the board had collectively agreed to lose one of the risks, which was around the agility. So we don't have 10 risks anymore, we have 9 risks, just for clarity, and therefore the numbering system. With that, Chair, I want to pause there for any reflections, questions, please, if I may.
Yeah, I just want to say, thanks for your leadership in this. This is complex stuff. And particularly like, the appendices that links, how the risk links to other issues, our priorities, patient flow, quality. I think it's important that, what I was going to say was if anybody needs any further sort of just clarity and to work through some of the detail, please contact Nabil, who's got quite a bit of expertise on this, and it is complicated. And I would advise, I'm sure you will, because you go to the committees, but help the committees get their perspective on the BAF and their particular angle on the BAF would be very helpful. Any comments to look to?
Observations and questions, an observation and question if I can. The observation, it is clearly complex, Nabil, and rather you than me. So, but at the same time, I think it's fair to applaud all the work that you and your team have done in a relatively short space of time to undertake this work that, in my estimation, already provides us a clearer picture of the risks and the assurances, but also the gaps that exist in those mitigations and controls. And I think it provides me, certainly as a NED, greater confidence that we're better able to identify earlier those risks. And 3 queries, if I could, and it's the so what, it's the here and after. If you can't answer now, that's okay. 1, do we possess a consolidated governance process, something like in an audit handbook, such as the HFMA publish? 2, turning to the global internal audit standards, do we comply with the essential conditions there? And if not, what are we doing? And 3, in terms of counter fraud and the service condition 24 of our contract with the NHS, does our standard return, is it compliant with that? Now, it may be too much to answer now, but just for you, if you could get back to us for
Perfect time. Usman has joined us to help me with probably the last one, which is the fraud question. So I will pass it along to Usman, but I think I'll try and answer the first 2 if I may. So I think in terms of the consolidated governance handbook, we are in the process of developing it for the trust. but it will take a little while before we get there, because it needs, what I want to do is I don't want to develop this into a kind of top-down approach. It needs to be bottom-up, and it needs to be co-produced with people who need to use it in the service areas, in the divisions. It needs to be a document that we can live and breathe and use in the package. So hopefully the aim is that by January that will be starting, by February we launch, and you will see that through coming to the committees, etc. So that's in the pipeline, not landed yet, but that's certainly the plan. That was probably one of the responses to the work we had Morehouse done, the governance review, before I started. So it is picking up the recommendations from that back into governance plus. Very much inspired by HFMA's view of doing it. That's my view. Is in terms of the international audit standards compliance, I think when we look at the work that the RSM does and also the audit do, from last year's assurances, I'm feeling assured that we are and in compliance with these standards. If we are not, I'm sure the audit which is about to commence, looking at our assurance framework and other aspects, will pick it up. From what we do is we reflect on all standards, regardless of it being international or local, and ensure that we absorb into the work. So it is all comprehensive, not only from international but local perspective as well. So that is, I think those two are my bits. I'm not sure if Usman is here with us. But
no, I do might have lost us, haven't we? Unless, so let's go to Abiela's question, then we can, if we can't answer it today, then we will.
Nabil, just, thank you for the, a lot of work has gone into this. And I think sometimes when we look at something like the BAF and it's so complicated and there's so many colours and, you just, let's just finish this thing. But actually, I think it's got real strategic importance for us, particularly when I look at Appendix 2, which is the risk appetite. And it is something that I've, raised before about understanding how some of those risk appetites clash somewhat. So, for instance, we have, for innovation, we said that we have an appetite that we're mature. So that means we're willing to do innovation. And I think when we had our patient story earlier, we're like, yeah, great, let's do innovative stuff, given the system that we're in and the times, we need to do that. But then when we look at finance, we're cautious with finance. And if anyone's ever done anything entrepreneurial or tried something new, sometimes it fails, but that's part of the learning. And I think sometimes what stops us with innovation is if we're like, I don't know, you could lose money on that. And we are supposed to be cautious with, with money, because that's what we said in our risk appetite. The danger sometimes is that we then are not as innovative as we want to be. And so just wanted to raise again that those things, as we are having very important discussions that we're going to have about the strategy and where we go, that we have to recognise that this is quite nuanced, that we still need to be sensible with the finances, because obviously, that affects, so many things, but we shouldn't allow that to stop us from trying something just because there's no one who's done it who can tell us that we're exactly going to make this amount of money in such amount of time and all of this. Sometimes innovation means risking money and time, and we just need to be aware of that.
Good comment. I mean, it's not a question, but I would want to respond to it very briefly, if I may. I would say this in my life, to make things simpler is the only way forward. And for risk appetite, I say this, and I say this quite vividly, nothing is real as real. And I think the challenge will be for this board to hold ourselves to account when decisions are being presented to us, they are taken by taking the risk appetite in the view. I think that's the challenge we need to hold ourselves to account. And going forward, we'll see that hopefully play out, not only in real time, but actually to ensure that we do that. So that's my brief reflection on that, as opposed to answering your question.
Yeah, I guess just give you 2 quick points from me. I think, first of all, thank you for all the work that's kind of gone into this. I appreciate the time and sort of the efforts. I think one of the things that's really helpful, again, bringing it through the board at this time point, is that within our internal audit schedule, we have the back on our quarterly, within the quarter 4 to be reviewed. So actually, I think that's really helpful because it means that our third line of assurance around this is actually quite timely before the end of sort of the financial year. So that again should then be, the feedback from that we can then come back to the board and the committees in terms of kind of giving the assurance around, yes, we think we've landed this in the right place, and actually we've put some external eyes on this as well. And then the only other point I just thought is just worth noting, not necessarily for expansion today as well, is just looking at where we do have two risks for which the committee is a subcommittee for them. So going forwards, I think it would just be worth it just formally making sure that against those two risks, we've got something minuted about the fact that we're comfortable with them because they don't default to a subcommittee underneath.
Okay.
Thanks, Chair.
Look, brilliant. Thanks very much. I'm going to ask Nabil and Usman to have a quick chat about the question on fraud outside, and then we'll get back to the board. Let's take a break, and we'll be back at 11:30.
I'll just pull out a couple of salient points from the overall summary, Chair, and then just move to questions, some of which I think we've covered already, particularly in terms of the focus on patient flow, but of course happy to answer any questions, and other colleagues, particularly David, I'm sure will want to touch on the quality aspects. So we obviously got 12 strategic objectives. We've achieved 3 of those at the target in month: ligature incidents in the community, inpatient deaths with cause of ligature, and implementation of core elements of the neighbourhood mental health teams. We've got 2 areas that are causing special cause for concern. One is around older adults discharge length of stay. So we'll be very familiar with adult length of stay. We don't talk about older adult length of stay. Adult length of stay obviously related to our National Oversight Framework rating. Older adult length of stay is similar, but it's based on 90 days rather than on 60 days. And that position is very much driven by patients who are clinically ready for discharge. At recent months, we've had over 50% of patients within our dementia beds waiting to move to residential or nursing placements, and then ligature incidents in inpatient settings within the last 7 months. However, it's important to note that whilst incidents are showing an increase, analysis shows that this is an increase in low to no harm incidents. 14 metrics within the annual planning and national performance framework are identified as under target: talking therapies, reliable recovery, agency vacancy, sickness, contacts by help, time equivalent, and community mental health survey satisfaction. 8 other metrics, 6 are on track or ahead of target. Corporate projects, 4 are on track. 1 is delayed, Coombe Valley Hospital. We've talked about that in previous meetings at some length, but happy to cover it. And 5 are at risk: community transformation, CAMS transformation, inpatient transformation, quality priorities, and EPR. I won't go through in detail the financial performance, because I suspect we will probably talk finance, particularly when we have an update from the F&I paper. I'm going to just pause and then move to questions.
Yeah, Usman, anything to add?
No, nothing particularly to add that John hasn't covered. I think it is just worth noting on the, I think just to emphasise on the ligature in inpatient settings, while that average of 7 is over the trend and above what we saw last year, the analysis we can now do shows that those are sort of the low harm or no harm events. Other than that, I think we just go take questions, Chair.
Can I just say, Sean, that we did note that as well at the Quality Committee around the change in the incident profile for ligatures.
Thank you, and I'm coming to David. Just John, on the older adult length of stay, as you say, we often talk about the adult length of stay wards. On the older adult length of stay, what's the plan for improvement on that?
So we've started to see some improvement. We've started to see a reduction in the number of patients who are clinically ready for discharge. I think it's a couple of things. So all the actions that we're applying through the length of stay work that we've been doing with our colleagues from Morehouse equally applies to older adults as it does adults. And we have a particular focus in East Sussex around the development of a virtual ward for patients with dementia. And again, it's much of the older adult challenge is around nursing and residential provision and availability within the social care provider market. So accessing the East Sussex Hospitals Trust virtual ward with a specific focus on dementia care will be able to support that.
Good. Okay, thank you. Abiola, then we'll come to you, David.
Yeah, just a quick question. I think I'm not understanding. On page 4, it's got contacts for clinical WTE. I always keep forgetting what that means. It's got 26 at M6 against a local target of under 27.3. I don't understand how that means that. Are we not supposed to be under 27.3? I'm not understanding what that telling me.
Okay, well, perhaps I'll start and bring in Usman. So clinical contacts per 8W whole-time equivalent.
Okay.
As in one whole-time equivalent is somebody who works full-time.
Okay.
Usman, do you want to just come in on the actual?
Yeah. So I think on this one, there were, as part of planning set, there was a set of metrics. In effect, the target is for us to have 20 more each whole-time equivalent, that clinical whole-time equivalent that we have. There is a target that they should be doing more than 27.3 contacts. And at the moment, we're under that, which is we're showing at 26. However, I think it is really important to know, and we've talked about this previously at board, is that this is a new metric for us. Within the details of the FIC pack, and through the Finance and Investment Committee, there are a lot of metrics around this area that we look at. And I think what we've been really keen to highlight is that there is still a level of work to do to ensure that we record and capture all of our activity. And I think we've talked about it previously, that actually this will change hopefully quite a lot once the new EPR is in place and we're in a position to record all of the activity that our teams carry out. And so while we record it and we show it, as we are required to and should, our focus has been on trying to understand the variation. And I think it's fair to say that in some teams, there are activities that don't happen in other teams, and therefore that understanding that variation, but at a global trust level, in effect, what this shows is at face value, we are under the target that we have set, i.e. each of our people should be doing 27.3 activities and contacts, and they're doing 27, which is why it's in red. But I think there is a bigger bit around waiting for the new EPR to go live, for that to flow through so that we're really in a better position to ensure that we understand all of our data access and collection. So I hope that kind of helps answer it.
Well, actually, I think it was just maybe the way it was written. It just looked like the local target was meant to be under 27.3. So that's what it just suggests it looked like in the paper, that maybe the arrow needs to be pointing the other way.
So on page 7, within the second page of the summary deck, I think I'm looking at the target and it says that it is greater than 27.3 is the target. So if there's something else we need to pick up, I'm happy to pick up outside of here.
That's fine. That's fine. Okay, I know David wants to come in, but let's take Kathy and then David, you can make your comment, but also start the responses. Kathy.
Yes, just an issue that we'd obviously done some good work engaging with parents around the CAMS transformation, and I just wondered if there are any interesting key messages back to the board from that engagement.
Yes, please. Yeah.
Yeah, there's a huge amount of engagement. I mean, a lot of it is the stuff that we would expect to see particularly around waiting times. So a lot around actually how are parents able to access support even whilst they're waiting for kind of interventions and stuff. What's come through though more so has been some really innovative ideas from some of the parents around actually what would they need better. So for quite often what they want is just a resource pack, or just give me an idea about, manage my expectations by telling me when you think I might be seen, rather than just telling me I'm on a waiting list and I don't quite know when. So there's some really kind of sort of low value but high impact elements that we'll be able to put in, very much based on the parent feedback that kind of we received. And then there are the bigger things around the access and the waiting time stuff, which we'll obviously pick up as part of our key priorities.
Thank you. Anil.
Good, that's helpful. Thank you.
Thanks.
Usman, do you want to come straight in?
Sorry, just very briefly, I just wanted to apologise to Abiola and the rest of the board. Abiola, you're absolutely correct. In the actual cover paper, sorry, I was looking at the main body of the report. There is a typo. The greater than arrow is the wrong way around. I apologise. In the main report, though, on the slide 7 on the second page for our exec summary, it is shown in the correct format. So we'll make sure that's corrected.
Thank you.
Thank you.
Chair, I'm reminded what John reminded the board earlier this year, and you invited us quite correctly. You were looking at me at the time, quite understandably, to sometimes to refrain from getting into the weeds and look at, as a board, be more strategically deliberative. I suppose with that in mind, I'm deeply conscious, and we can only applaud as a board, as we must, the very considerable efforts of so many in this organisation And I certainly mindful, and visiting Linwood on Monday was a useful reminder of the significant competing pressures that upon all teams to deliver more, oftentimes with less. At the same time, when I look at the IQPR, I think a casual observer considering that reasonable in thinking that although there are pockets of very positive performance, the overall theme is one of fragile, perhaps inconsistent improvement, and worse still, performance that is well below target, and when we compare it to our peers, less than them. With that in mind, and here comes a strategic question if I could, in your estimation, Oliver, others, does it require this board, this organisation, to fundamentally rethink the way we do business, including in particular our models of care? Big question, we can't answer that now.
Okay, but let's have a couple of responses to that. And Oliver, you're gearing up. So, James, it's another lozenge. You still have your.
Shall I take the models of care? Because I'm not quite sure I'm understanding what you mean by models of care. Because when you say models of care, I have a.
It could include care pathways.
So for me, there is a service architecture that we need to build. And that is driven by national guidance. And so, for instance, the community mental health framework is really the philosophy that underpins our neighbourhood mental health team model. And that framework and that model anticipates what we are being asked to do from NHS England around the 10-year. It is all about the left shift, prevention and digitisation. So I would suggest that our models of care are the right models of care to pick in order to help us address the challenges that we face. So we're getting early feedback, for instance, from the neighbourhood mental health team model, where we're now in this town, Worthing. We had yesterday I presented an award to the neighbourhood team of Worthing because of the feedback they were getting from their GP colleagues. So we had GP colleagues send 2 pages of feedback about the way the integrated collaborative working style was helping them much more effectively understand the needs of their patients, was able to provide real-time reassurance to them, and was also able to prevent referrals. And so it's that sort of working collaboration which is a need, and which is what we need to do in order to take that recovery and make it more consistent across the board. So the neighbourhood mental health team elements that are part of this year's objectives are fundamentally, they're crucial because they're going to provide the bedrock across the organisation. So we need to do what we're doing in Worthing, we need to do that everywhere.
I'd like to add a bit as well to the models. We take it out a layer. So all of us talked about the sort of systems and models that we have within our organisation. Just to really get some traction here, we could do with, as Kathy was talking about earlier, what support you need from the wider system. We've had some conversations about the delegated commissioning budget around learning disabilities. We're having conversations with our ICB, wonderful partners, about the Mental Health Act, the mental health budget, because at the moment we've got the voluntary sector housing, we've got education, we've got schools in mental health in schools, programs, psychological therapies. It is all quite, it's not so connected. If we get more connection with that and then get more influence on that wider pathway, we can then start, can't we, Oliver, adding to the social models to boost up what we do. And I know, because evidence says it will have an effect on some of the outcomes. Let's come to Jane though as well, I think, on this.
Thank you. So there is, in parallel to this, there's work going on nationally at the moment around the modern services framework. And there is a particular work stream for severe mental illness and mental health services. I'm the chief exec person on that national board at the moment, so we haven't started yet. We're starting next week. So I think there's a place for us to be at the forefront of where the thinking is nationally, and thinking I'll be in a good position to look at good practice elsewhere and bring it in, because I think we are driving forward change in adult services. I think we're further behind in CAMHS. I think CAMHS needs a significant transformation. I think we've got our path set for the adults, and that feels like it's the right path and it's in line with research and it's in line with best practice. I think we're at the very preliminary steps of CAMS, and that's where I think we need the more challenge. And with the adults, I think we need the challenge to make sure we stay on track and we do it at pace.
And we've got to think outside just what we provide and what we do, because we're dependent on the interconnections throughout the system. So David, we're coming to you now. Yeah, at long last. Yeah.
Well, thank you, Chair. So I think just on the CAMS, I think the opportunities now, and I know we'll talk a little bit later in Private Board around the CAMS pathway. There are opportunities now with the Chalk Hill development to look at that right across. Just picking up a couple of things in the IPQR. So Lynn helped me point towards this. But in Lynn's quality report, there will be a recommendation around the objective around ligatures. So the team have been doing a lot of work around ligature assessment and training. As we're shining a spotlight on it, we've seen a healthy reporting. But we've seen significant reductions in harm, which is really positive. So the objective at the moment is around all ligature incidents, whereas we would like to move into a harm arena on that, because I think we probably will continue as we develop some pilots around the assessment of our inpatient environments. We will probably see potentially a further increase in there. And the second one is around, I just wanted to comment around the physical health in the IPQR. So the physical health assessments is one part, but one of the things that Oliver and I have started to have some conversations about is realising that the physical health with our serious mental illness, actually, there's a whole public health side to this. So we've joined up with public health, and we've got some meetings this week around obesity and smoking cessation, because we know we're not going to solve this on our own. It needs to be jointly led with our public health colleagues.
That's good. We need to close. We'll go Colin and from
Yeah, I think just a reflection about that sort of strategic overview. If you just look at the exec summary and what does it feel like, I think that probably it does feel fragile. I guess the point I would just draw attention
to. I was looking
at
the entirety of the IQPR.
Okay, sorry.
I'm looking back at the SPC charts over 2 years. It wasn't simply a snapshot.
Take the point. I think for me, one of the things that does stand out though here is that there is a cluster of metrics which are all very interrelated. So actually, you know, if you think about the length of stay, the CRFD, and the ED kind of sort of waiting time, you've got a cluster of metrics that are very performance focused, which relates back to sort of the update that we kind of got in sort of that chief exec. So as a board, we deliberately set a lot of our strategic measurement this year's around inpatient and flow, because that's where we felt that there was significant amounts of kind of sort of challenges. I think there's a number of areas, certainly I'm happy to talk offline around some of the transformation programs which are currently sort of at risk in amber, and I think some of those are quite cautious and also relate to some of the interdependencies that we've got with other partner agencies with it. So I think there is a level of fragility to it, but I think if I was to funnel that down, I think the fragility is where a lot of the focus of our conversation is, which is around it's that flow bit. If we can nail that flow piece, which absolutely the solution sits in the communities, as much as it does within the inpatient provision, then actually I think that's the dial turner that we need to really overall sort of move it.
Yeah, that's good. Very, very good strategic question.
Thank you. Colin said half of what I was going to say. So the other half though was around our planning round, and I take Anil's point, question and challenge. And I think that the real test to that then is when we come back to then say, here is what we are looking to focus on for year 2. I think the question or challenge to us then is, are these the right things? Great. Therefore, to help deliver on the things that pushes us out of that really fragile space into starting to build what it looks like to have some stability. I know certainly that's what I would be looking for. As an exec officer, to say, are these the absolutely right things that we should be doing in year 2? Because we know in the 5-year vision, we plan to do it all, but for year to others the right things. And I think that's where we could do with that real challenge.
Great. Thanks very much. Thanks very much. Moving on to delivering high quality care consistently being employer of choice. We've got a nice, so I think it's quite a good format here. Going to get an overview from me, an overview for David, and then we go into the quality committee feedback with the attached reports from me.
Thank you, Chair. So what I'm hoping to do at the next board is to bring a scene setting paper that sort of tells us the full picture of how our people fit into everything, because I think we could do with that. We haven't had that in the last 4 quarters, so I thought it would be really good bringing us back around the table, and then that helps us to then see and understand where it is we want to go. Now, this is coming from the point of view of our people costs, well, for the NHS and certainly for SPFT, and account for more than 90% of our costs. So those points, if we are thinking about modules of care, we're thinking about the service that we deliver, we're thinking about culture, we're thinking about leadership, we look at our BAF. The one thing that is consistent through all of it are our people, and we've got about 6,000 of those. So my thinking is around how we get the board around the idea of how can we effectively come around the topic and the subject of our people, who are the largest cost. So ultimately, if we come to that, then we talk about design, capacity, capability, and all of those things. It comes back down to, do we have the right plan and the strategy for our people? So I just wanted to see that as a scene setting before Lynn will then sort of share later where we discuss the quality committee, which is where the people agenda currently sits. Thank you.
I agree with that work would fit very neatly and closely to the continuous quality improvement program.
Absolutely.
David.
Yes, not a great deal more to say other than I think the work that we're doing and the work that Lynn and I have been working together on the quality committee and the developments of the quality committee, and I think it feeds very well into the quality governance review, which we'll talk about a bit later, around how we see and how we give across board that level of assurance around the quality assurance aspects within the organisation. But also how we move into the improvement space where we see that. I won't steal too much of Lynn's thunder, but we're going to have our quality committee workshop in January where we flesh out what the quality agenda, the quality committee, how we get that effective oversight, because it's an opportune time now with Lynn as the new chair coming in. So I think this will drive it. And I think also with potential changes in people and culture and quality committee, that will give a better sharp focus on the quality committee.
Yeah, I appreciate you two have to work so closely together. I appreciate that. We're working together with that and advising I think a look at the quality committee. So you've got a special workshop to take over. Yeah, that's really good. Sounds sensible. Yeah. Okay, thanks. Linda.
So my report.
Yeah.
If someone wants to say any more and don't. One thing I would say is that we did as a committee review that, so that was good.
Yeah.
That was quite timely for us, but it was quite useful. And the other thing to say is that we've had some strategic conversations with Cheryl as well around what the committee might look like going forward, how it might operate, and get the best out of everything. So we'll do that after the workshop. The thing that we need to do more of, I think, is demonstrate learning. And I think when we look at the issues of the change around ligatures, is to really understand why that is and make sure then that we can consolidate improvement and spread that and not just across ligatures, but from all the SIs that we see as well. So there'll be these narratives coming out, I think, in the future.
Fantastic. Thank you for Chair, just on Coach Abiola, and the review that we're carrying out, you're part of the bill. I'm just thinking the bill keeps us on the right side of what he's writing.
I don't do anything with that.
Me neither.
I do it at my peril.
Abiola.
Yeah, I'm just looking at 2.2 about people and culture, because obviously we know culture is an issue, and there's a lot of things that we want to do with the organisation, and we can't do any of that without our people. So where we're seeing that sickness absence rose, I mean, it's 0.4%, but still, I think I just want to just understand a little bit more what's underlying that, what's going on there. Is it more physical sickness? Is it more mental health sickness? We're a mental health trust. We should be at least helping the mental health of our staff. Pops to mind. I know that we're reviewing the occupational health contracts. Is that because we think they're not delivering, or it's just the natural course? It's come to the end of their contract, and we just, need to change that. I just think, I just want to make sure that for us to do what we need to do, our staff need to be in the right place. It's like, if you want to do, something with, someone, you don't go to them when they're tired or they're hungry or sick, and so if we're going to ask our staff to do all these great amazing things, let's not go to them when they're sick. Just trying to understand what's going on there.
Thank you, Abiola, and I think this very much aligns with what I was saying earlier around the that need for that scene setting, which will come the next time. But to your point, when we talk about where we are with our people team, we see the impact of where the organization is, and that the first place it reflects on is on our people. And this is why it's really important to think about the connection between quality people and finance, because they are all interrelated. So the short answer is we have seen a spike in sickness absence. There is what we call a seasonal spike around the winter, which is normal across all NHS trusts. There's an uplift starting from November right through to February because of colds, flus, and the likes. In SPFT, we have now seen what we call an out-of-season uplift. Now, we know that is directly correlated to the significant volume of change. Last year, for context, SPFT had 80 programs of change, 80, where people were subject to organizational change. It will be disingenuous to say that it will not have an impact. To your question, where is the categorization of the impact? The highest cause, over 33% of our sickness absence, is down to stress, anxiety, and depression. So it's not colds, flus, and coughs. So it's that recognition, knowing that we therefore cannot not do the change. What we then have to do is ensuring that we have a strong and tight occupational health and well-being plan in place. Now, I like to say we have a very good plan in place because I've compared it with many, many other organizations. What we have to do is make that more accessible to people, make it more available across physical well-being, financial well-being, and emotional well-being. SPFT do have a very good package. Why are we reviewing the contract? It is up for renewal. It was a 3-year contract. We're coming up for renewal, and that's why we are doing that. And updates will go to quality committee on that as well. So, but it's very important for me to stress that they are correlated, the impacts that we are seeing on the workforce. Thanks, Marie.
Dan and David. Well, should we take Shell? And Adele, actually, Adele wants to come in.
Yeah, sure.
Let's take Shell and Adele in the form that I'm introducing this board piece, and then if we go to you and David, then you can do the response.
I think so. I'm going to just respond really directly to your point about sickness absence. I think it's the point you make around occupational health and that health and wellbeing are really important. The data shows that actually the biggest difference to people's stress and mental health in the workplace is their line manager. So there's something about, the work we do around leadership essentials, but actually as a line manager or a leader, how are we really equipping those people over an extended period of time so that it's not just I've got my training and now I'm out there, or I've been enrolled for 2 years and then I get my leadership essentials training, which is what it's like so often. We know that how leaders, direct supervisors, manage change, manage their people on a day-to-day basis, those are the things that impact the sickness absence.
Yeah. and all the work I've seen you do recently with the senior leadership team and frontline managers training and stuff. That is so vitally important. I know.
Chair, with your forbearance, I've got two questions, if I could, please. The first is risk informed. The second loosely describes something to do with culture, if that's okay. First, Lynn, thank you for your paper and the appendices last night. I was trying, but I've got to accept failing to aggregate the information as helpful as it was. My question is, from your perspective, sat on that committee, and I don't sit there, what's the most significant risks that you see from multiple perspectives currently?
The most significant risk. So I think that the work that's been done around ligatures obviously has taken account of where things weren't so good before, has clearly had an impact, and so that it would be very easy then to think that there's a situation that has been resolved, and that will never be the case. So there are some things that just will always be there, no matter what we do, whether people are lecturing in our services or at home or whatever. And that's why I mentioned learning. I think the risk for me at the moment is not being cited on seeing where the learning's coming through and where it's being spread across the organisation. So that there will be things happening in various places. And I can't yet see, and it doesn't mean to say it's not there, but we talked about this morning, where you can actually find this has happened, this is the learning, and this is how staff have reacted across the organisation, and what we've done to support them to do things in a different way. So I think that's one. So that's a big thing. I don't think that the board is necessarily cited in the way that I would hope it would be on things like serious untoward incidents and being able to understand what happened and what's being done, so that we can assure us that things do go wrong. So these incidents will always occur, and we need to be able to say, we learned from that, and here's the evidence. And so I think because we'll improve in that way, and we're very carefully linking it to our improvement program, they shouldn't run as two separate things. They're all part of the same thing in terms of quality improvement. So I would say that they're my top two.
These are really good discussions. I'm going to bring Jane at this stage, and then we've got Dan Davies.
Sorry, Chair. I did have a second question about culture, but sorry, that's completely separate to this. Yes,
yeah, it's the same question. So I think in the private board we've got the first draft of the quality review, and that points to my I think is the biggest risk for us, and that will go through the quality committee and then come back here formally. But I asked for it to be brought to private board because that's my biggest worry, is consistent delivering quality of care consistently, triangulating data set fits exactly with what Lynn's saying. Are we consistently learning? Are we consistently embedding the learning when we actually do it? And are we cited as a board on the consistency of practice? So I think in private board we'll see the first iteration of that, and then it will come through quality committee. And I think as a board we've got to pay attention to it.
Very good. Yes.
Jeff, I could. Colleagues will remember the sobering judgment of the two within the Too Hot to Handle report from last year. And I think a précis of it, it goes like something like this. There exists a culture of avoidance, of defensiveness and minimisation of racism within the NHS. If I could broaden the scope of this inquiry, if I could, to discrimination in all its pernicious forms, my question is, with that in mind, if we were to speak to staff today, what would they be telling us? How are they feeling?
I think we have two data points that tells us that our staff survey being one, and the second being our res. If I took it specifically within the racial context, what we have seen is in the last 2 years there has been a decline in the experiences of our staff, particularly when it comes to bullying, harassment and discrimination from staff who are from an ethnic minority group, but also from staff who have a difference, so disability and sexual orientation. There has been a worsening, and this is coming off the back of a significant improvement in the first 2 years. So what that is showing us is either, so to Cheryl's point earlier about the role of the manager being so important, one of the things that we're picking up through Leadership Essentials is how to equip managers to still think about well-being as significantly important as opposed to a nice to have in the face of significant change. Mm-hmm. So that is the theory, and I say theory because it's not fully proven, it's only anecdotal at this point. But yes, the facts on the ground is that experiences have worsened.
Anisha, I'm going to bring the bill in actually because you've got a particular question actually quite relate to the company secretary role.
Well, not company secretary, but just per se. I think the other work that is ongoing is the Trust's work with the National Health Observatory work. And we've had a fantastic roadshows led by Habib Naqvi, the leads on the ethnicity pay gap, which is a very related point, bringing the staff experience into the fact. And also there is a report on sexual safety and violence and aggression, which we are working with them. I think it's an important feature for us on that improvement journey. So I just wanted to say that we are working very closely on those fronts with Finley's leadership. So
they've asked Jane, they asked you to.
The regional event and pay gap for the NHS races in Brighton. About 4 weeks, 3 weeks, I can't remember when it was recently.
So we need to keep this high up the agenda, don't we?
I'm going to thank Lynn because I thought that not just, but in particular, attaching those various appendices for someone who isn't on your committee allowed some reflection, really.
Yeah, and I think that question is going to prompt you're reviewing the committee, and one of the things we do know about the committee, there is so much going on that actually getting the papers succinct enough to zoom in on the real issues that matter is something that I know we're working.
I think I described it as you cannot see the wood for the trees in the way that the papers come into the committee. It's volumes, and we don't sometimes do them justice, and that's the whole need for the strategic review.
And from you, Dan and David. Sure.
That was going to be my point. I think the biggest risk I see in the Quality Committee, only having been to a couple as fairly new led, is that there's too much on there. And that it's really, I think we really do need to split people and quality. And I know that does bring with it other difficult issues, but I think fewer reports with more opportunity to challenge and scrutinise on both sides, because I actually feel that we've stolen time, from quality, having gone first with people actually the last couple of sessions. And by the time you get to quality, it's almost like there's fatigue, in the room. The other point I wanted to make was your question about what staff are thinking now is exactly what goes on in my mind as I go to a site visit. And I think there's a real disconnect between how staff feel on the ground and how they feel about us as a board. And again, it could be anecdotal. I've only been to a couple of places, but, I'm all right here and I feel supported by a immediate line manager, but you lot up there, and this is what you're doing to us. I think that disconnect is something for us to be really thinking about, because it's about how we communicate.
And that's worth us exploring at a bit more detail later. But it shows the value of the visits. It shows
really
the value
does.
of getting out there and speaking to staff. And we didn't do that probably enough a little while ago. We are upping the rate on that.
Yeah.
And I thank you all for it, because I know it's time but it's really, really useful. Dan and David?
Two things. One, to your point, Lynn, when I think about our complaints improvement programme and the focus on learning, a really important element of that is the action that flows from the learning. So being clear about it, being clear when you've done it, and being able to evidence that. A broader point that relates to Pumi's earlier comment about planning in relation to quality. When I think about year 2 of our organisational strategy, I think the question for us is, are the actions right to deliver the improvement that's needed? Are we focusing on the right outcomes? So at our planning workshop earlier this week, from an experience perspective, I was saying we need to take a much more rounded, sophisticated view of how we measure experience that goes beyond surveys, that looks at the findings from inquests, that looks at external assessments, and that also looks at qualitative feedback.
Thank you very much. And just a couple of very quick ones. Can I just check that we're happy with the recommendation in Lynn's report around the objective moving from 10% reduction in ligatures to a 10% reduction in harm? Just so we can. Yes. Is the Trust Board happy with that?
Yeah.
Thank you. The second one is around the learning. So we're in the middle of writing the learning framework. Speaking to Lynn's point really, because I think there's a lot more for us to do in joining the improvement agenda. So we've got our first learning conference now, which will be quarterly in January or February. We launched the learning bulletin in December. So, but part of the framework around the learning is that how we test that the learning has happened and has resulted in changes in practice. The final bit is we were very aware of the amount of reports of quality committee, hence the workshop. We're also aware of that third committee below, which is the QRMC. The quality group that we're doing operational bits of quality that will take some of this away from the other two groups, that will allow us to talk more about the improvement, but also to have that debate, discussion, and help and challenge around what we're seeing in our data. Whereas at the moment we're going through our reports, but we need to create that capacity to have that debate and discussion.
Okay. Thank you very much. Great. Thank you very much. Yes, moving on to the Mental Health Act Committee. Cheryl, I think you're second.
Yeah, thank you. I just want to mention the main report that comes to us is the Mental Health Act Committee and Dole's Integrated Activity Report. I think this is something that should come round to you as an appendix, like Lynn has done with quality, because it is a really fantastic report, and I think Alison has been working really hard not only to pull together the data but also to service what we're asking for in that committee. An important part of the committee is the work that we do with the associate hospital managers. So we receive a report from the associate hospital managers in each committee, and they give us a level of insight around how their role is working, some of the issues that they're having. And Alison had pulled together for us and some nice information around cancellation and postponement of hearings. And it also allowed us to get underneath the size of the work. So in the last quarter, for example, there were 227 tribunal hearings, but only 158 of those went ahead. So we're getting underneath some of those. And a recommendation from the committee is actually that we begin to use CQI to think about how we can smooth out some of these processes, and that's, we operationalise the conversations we're having about continuous quality improvement. We're receiving quite a lot of information to the committee that is quite operational, it's quite delivery focused. So we've asked Oliver to kind of help us a little bit with that, so that people know that they don't have to come to the committee to get things sorted, if there are particular issues. So we hope that will see an improvement in the experience of those independent practitioners. We received a report on the CAS review summary, and I'm sure lots of you heard on the news yesterday, this is getting a lot of press at the moment, particularly around the clinical trial for young people. I know Kemi Badenoch brought it up in the House of Commons just this week. The report we got was excellent. Jane McCarthy was asked to step in at short notice, but it did lead us to ask questions around what should go to quality and what should come to the Mental Health Act Committee. But more importantly, I think this report needs to be read by the whole board, because I have to say it helped me gain a real deeper understanding of the issues, which I think all of us need to understand. The prohibition of puberty blockers for young people, the clinical trial, and the establishment of 2 centres across London and Manchester means that a number of patients that were waiting at the Tavistock have now come back into Sussex, and our staff are both needing to be trained and find time to look after these additional patients. So that's important for us to know. We received a report on CQC preparedness from David, and that also went to the quality report, committee. So I won't add anything on there. But just to say, finally, on the integrated report itself, if I picked out 3 things that I would want you to know as a board, Section 136 detentions fell 3 times more than the national average. So we've just asked why that is, and we've asked for a deep dive into that. We noted that there were CQC inspections at Blossom and Oaklands. They were both excellent. I think Raffaello, I want to say, is that correct? There was a few issues there that need picking up, but on the whole, a good CQC report. And we also asked for a deep dive on community treatment orders, because we're seeing a rising number of the use of community treatment orders. And my first question as a layperson is, well, is that a good or a bad thing? Oliver was able to help me with that, but we want to look into that in a bit more detail. So I hope that provides you some context to what we're looking at in the committee. And Oliver, have I missed anything?
Yeah, I think that was pretty good.
Bringing in John, and I wondered about Section 136.
That's what I was going to come in and just to join the dots, I think. So the significant reduction is great. So Sussex has often been an outlier in the number of people who've been detained on a 136. So there's a couple of reasons. So one was the development of the blue light line, because it's been agreed that is the single point of contact for Sussex Police to seek clinical advice before they detain anybody on a Section 136, and the development of the Rapid Response Service. So again, instead of them detaining someone on a 136, they will convene on the scene with a nurse-led service. And more recently, Sussex Police have said they will not take any clinical advice from anyone around 136s, with the exception of the blue light line, because they have there's an NHS England commissioned service in custody, nursing service in custody, but they feel more confident in taking the advice from the blue light
So
line.
it's consistency, I guess.
Exactly that. So all of those measures have made a significant difference.
So we're now getting quite established at having the Mental Health Act Committee. It's properly constituted, report back to the board. That's an improvement, isn't it? And really, at some stage, I suppose we should have a focus on the review of the Mental Health Act that presumably is going through government and the implications for us, and are we ready for that? And then lastly, I always think that the brilliant programme on PQRA, patient-based quality framework, patient care quality framework, there's an overlap there, isn't there, with what it's going on with the Good. Okay. Thank you very much.
Can I ask a question, Sean?
Yeah. Simon.
So can I just check with the CAS report and the clinical trial? CAMS is obviously not specialist, and you've got the regional specialist centres. Are we utilising the voluntary sector support? I know the gender clinic, which we have, is the for adults, but there is quite significant voluntary sector support within the area, and given that we know how problematic lots of the other pathways can be, I wondered whether there is any work that we can just be assured young people are getting some of that support at a really difficult time.
Yeah. John, sorry, John. Yeah.
Thanks. Hi, Simon. Yes, we are. I can speak specifically for Brighton and Hove, where there's an organisation called All Sorts that works with children and young people, and our CAM services work very closely with them. So yes, that is in place.
Can I just, maybe this is an offline conversation, John, but that's not one-to-one support as such, is it? That's more sort of youth group type support, isn't it? Maybe we can talk offline, but I was thinking more about the Clare project and others who are more connected around pastoral sort of care.
Well, the Clare obviously work very closely with our adults gender service, and obviously they're a key partner in delivering it. All Sorts have been commissioned recently to work specifically with a group of children in Brighton and Hove, but that's probably best taken offline.
Okay, cool, thanks.
Is that commissioned by the ICB?
Yeah, that's right, yeah.
Right, okay, thank you very much. So, for an organisation to be sustainable, the next item is the Finance and Investment Committee. Anil, you chaired it. Thank you very much.
So forgive me all if I'm looking down at my notes. I don't need to be discourteous. This is a canter through the FIC meeting that was held on the 28th of November last week. I'm going to proceed on the basis that you've been able to read and consider both the Chair's report, but also Kim Butler's Month 7 report. I don't propose to recount large tracts of that. You will note that there were a number of usual standing items, but the focus of our discussion led us to the medium-term financial planning in particular, and also the financial recovery plan for next year, both of which I'll come back to if that's okay. Whilst no new risks were identified, nor was there any recommended uplift or change to the 3 strategic BAF risks, at the same time the Month 7 position was as such. The year-to-date position at the end of October, year-to-date deficit of 3.8 million, which was 1.3 better than planned. The SIP delivery of 2.7 million in month, or 15 million year-to-date, which was on track. And although we've seen a reduction in agency spend, total temporary staffing costs was over cap, 1.1 million in month and 4.2 million year to date. And that's largely driven by the bank staff usage. Overspends on non-pay were largely due to PICU, independent bed usage. In terms of cash, our cash balance, 92.8 million, but before Osman gets giddy and becomes a tax exile, a large proportion of that was held on behalf of provider collaboratives and also the capital programme. There's no forecast pinch point in that we can't cover for the remaining in our cash balance for the remaining four and a bit months of this year. And in terms of both aged creditors and debtors, they're all within policy and acceptable boundaries. Turning to the FRP, if I could, colleagues will remember that at the beginning of this year, financial recovery plan totaled £33.8 million. 22.9 million of that efficiency was on a recurrent basis, 11.3 on a non-recurrent basis. There's a forecast variance in the SIP delivery plan of 8.3 million. That's driven predominantly by underperformance in workforce optimization. That being said, that amount is being mitigated through new and largely recurrent technical schemes that we discussed. In terms of the forecast position looking ahead, looking at next year, the projected underlying deficit going into next year is 13.5 million. And if we could just take a moment to understand what that means. Colleagues who are more seasoned in this trust and more generally in the sector will know that not so long ago, just over 2 years ago, this trust possessed an underlying deficit well north of £50 million. It is currently, or forecast to be, 13.5 million going into next year. Well, what does that tell us? Amongst other things, it tells me that about prudent financial planning, and at the same time, and moreover, a great deal of effort on behalf of all our staff across the trust. And whilst no one wants to go into the next financial year with a structural deficit, at the same time, it's important to recognise and applaud the hard work. Looking at next year, if we could then, come in, Osman, if I get this wrong, before efficiency savings, the risk-adjusted deficit forecast at 34.4 million. Which then brought us, I think, the mainstay of discussion, and I think it's fair and accurate, Abiola, Simon, Osman, others, please correct me if I'm wrong, to say that there was a loose consensus arrived at that whilst there's significant opportunity in addressing variation in performance and the critical need to make productivity gains, At the same time, there's a need to distinguish from an approach that is transactional, that will enable us to survive in next year and in successive years, between that and being truly transformative, that will ensure that we can thrive, not just financially, but much more over the longer term. I suppose in being strategically deliberative then, the injunction of that discussion, so that perhaps as a board, the epilogue that's written about us is more positive than a positive one that we'd hope to see, is there a critical, urgent need, to my earlier point, Oliver, and notwithstanding what you, Colin and others have said, as part of our CQI agenda, to embrace further what I would describe as truly transformative change beyond that which is currently envisaged.
Yeah. Thank you very much. Bring Usman in. You had your hand up a minute ago, but Usman, please, your opportunity to come in.
To be honest, Anil has covered, I think, very well the entirety of the report. I am redundant to purposes, so I'm happy just to take questions, Chair.
But what's the next stage, Usman and Anil, particularly around the next year's financial planning?
In terms of next year's planning, board members will note we've got a separate section, as people will understand, within the private board. So we'll go through in detail there, a bit more detail there, some of what Anil was talking about, understand the sort of potential challenges and risks, recognizing that we've got to make a draft submission on the 17th of December. We have got an extraordinary board that has been stood up in effect so that we can do the approvals for that process. But later on this afternoon, we'll go through in a bit more detail the decisions that we will need to make as we sort of come up to that submission point.
Fantastic. I'm bearing that in mind with three non-executive questions. Just bear that in mind. We're coming back to it in a bit more detail. Kathy, Nitin and Simon. Kathy.
I just really wanted to applaud and commend the approach that is now being taken to really seeing that transformational change. And for me, that starts to sort of join the dots between, you know, quality and patient outcomes, money and our workforce much more sort of obviously and coherently, really. And I think that's a story we should be telling to our communities, to our patients, to our staff, that actually this is about evidence-based improvements for those pathways. Yes, we're going to ensure we're financially sustainable, which we absolutely need to do, but it's a much bigger story, I think, and I really welcome that, and I really welcome that approach, and I look forward to CQI becoming embedded and helping us with those big, heavy lifting transformational changes. So thank you.
Yes, and as Anil was saying, we've got a good track record in that, in articulating the narrative of the last couple of years, where we've made substantial savings by modernising, transitioning services to be more effective and efficient, but of course more value for money. Simon.
Kathy said everything that I was going to say. I guess I would just underscore the link to the staff sickness conversation earlier. You know, the salami slicing and lots of change programs feels for me much harder for teams to deal with than bigger change. And I'm really keen for us to embrace, you know, that connection across the quality, CQI, staff survey and finances, and make sure that we're clear about that they are all part of the same thing, not three separate tracks.
Nitin, please.
Thanks, Chair. I had a question on one of the appendixes that you have, workforce usage against plan. And Usman, maybe you can clarify this. There's a chart there that talks about staffing actuals against workforce plan. So and it has got this bars going across, talking about, you know, staffing actuals in August, May, June, July, August, September, and there's a red line at the top which says workforce plan, and the line starts pretty.
Page 7 of 20.
Sorry, I should have mentioned the page number. And the line starts there's a big gap between that line of workforce plan versus staffing actuals in the months that we have actually covered so far. But going in, that line is dropping, which means our plan is that our plan was that we'll have much reduced workforce going in. Is that how I read it? That our plan is.
Yeah, do you want me to come in? Sorry, Nitin, didn't mean to interrupt.
Yeah, sorry. And if that is the case, then I'm not seeing the actuals drop. Then can we actually deliver on that projected workforce plan in the coming months when we're seeing that drop?
I will also bring for me in as well. But on this, so the reality is that the original plan that we submitted reflected let's call it the last minute changes to our plan, and the additional savings that board members will recall that we had to in effect find to ensure that we were able to deliver the break-even plan. At the time of that decision, we were also required to submit a triangulated workforce plan, and I think as we have already previously said, there was a mismatch between what was initially submitted and then what our final plan ended up looking like, because in effect we needed more time to work it through, but that didn't coincide with the very rapid requirement to submit something at that point. We have subsequently done that. So the answer to your question is I don't believe we will achieve what is set out in that red line, but cumulatively year to date, we will get to a position that I think we have subsequently agreed that will be our formal position with NHS England. And I guess the reality is we are going to have challenges as we go forward, as we've previously discussed, around the fact that we're already over the caps in some areas, and there are some challenges around our ability to deliver that, is notwithstanding all the work that's happened. I think the other really important thing to note is a number of things have happened that were not planned at the start of the year. So the expansion in terms of the resident doctors, the transfer over of the LDA teams, it means that actually there were things that happened that have rightfully increased our whole-time equivalents that were not within the original plan. So I think as we go through the rest of this year, we will not achieve what is on that red line, but we will achieve the plan that internally we have been working to and we're setting out. I think it is important to say we should not downplay the fact that some of the savings in terms of the substantive side that we are making, are in clinical spaces that we want to be able to improve. Like we want to be able to increase the whole time equivalence in those areas. So that isn't for want of, no one is holding roles on Palmyra or etc. because we want to. We're still trying to actively recruit. So that will flex. But hopefully that covers it off for me. I don't know if there was anything else you wanted to add.
Thank you, Usman. I think the only thing to add, Nitin, is the breakdown of the workforce is made up of our substantive, our bank and our agency. And when we look at the more detailed breakdown, you will see that we are dropping for our agency and our substantive staff, where we haven't been able to Usman's point, where we haven't been able to drop to that degree is within our bank population, where we are over cap, which is also mentioned in Anil's reports because of the under delivery of the workforce optimization program. So we can see a direct correlation between the overusage in that space. And I say overusage, it's actually we're using as we used last year, we're just not using as low as we thought we would be using this year.
Yeah, and also, to acknowledge that you, Usman, and your colleagues are good at responding to the unplanned issues and circumstances and pressures that come through inevitably throughout the year. You mentioned, for example, the industrial action of resident doctors, and we do that rather well. So thank you. We need to close this up, Abiola, and then we'll let you.
What I think I'm going to reiterate a little bit what other people are saying, but I really just want to stress it, maybe just be a little bit bolder in saying, some of the things. I think our finance team are amazing. Just the team of people that we have who are working on different areas of finance, trying to pull this together, come up with a finance plan. Miracle workers is what I think that we've been asking them to do, and they've been doing. But I sit there and I think we can't keep asking them to do this miracle thing, that it's kind of getting beyond the Finance and Investment Committee now in terms of coming up with the financial strategy that's going to help save us. I think we need to think, and we've been having discussions, so this isn't new, what I'm saying, that something really does need to change. We're really beyond the service design, which Oliver's doing and is doing really well. I think because of the pace of change that we need to achieve and just the scale of money that we need to save, we are going to have some very, very difficult conversations very soon about what we stopped doing. We are just in that place, I think, and I think that is beyond the Finance and the Investment Committee. That is definitely something that us as a board, we have to just sit there, blank sheet of paper, everyone just like, right, what do we do? What do we stop doing? What do we get other people to do? What do we do more of? What do we change? Because, I can't see them continue to deliver this miracle anymore.
What we're about as a board. We will collectively come together and work on that. Jane, I know you want to
I just want to come back. I completely agree. We've got an absolutely fantastic finance team. But I don't want people to think that there's an impression that we've made these significant changes through finance. We haven't. Yeah. They've helped us with some parts of it, but actually it's been clinical and operational staff and people on the ground that have made these changes. And the quantity of change we've made over the last 2-3 years is pretty unprecedented in the NHS, and that has been through radical service redesign. It hasn't been through salami slicing, and that was a conscious decision of this board. I think we've done it at a pace that is stretch and bordering on too fast, but we also know we've got more to do, and therefore we've got to get into that space again. It's not a new space, it's a space we've been in. And I just want to make it really clear, we haven't been salami slicing, and it hasn't been driven by finance, it's been driven by the whole exec team and the senior leadership team. And I think it's really important to say that, because I wouldn't want anyone to be under the impression that it's about accountancy and things like that have made that significant, over £40 million saving that we've made in 2-3 years. But I do take the point, they are fantastic. Yeah. And I think the Quality Committee has also had a really important part in doing the quality impact assessments on the work that we've done to make those changes. The Audit Committee has sense-checked what we've done and double-checked. So I think it has been driven by the whole board. But I'm not downplaying us when the finance. You are fantastic.
Yeah, but I think what I would say. Finance team, there's just so it doesn't happen in all organisations. Sometimes your finance team can sit in the office and work out the plans. They're out there all the time talking to the managers, senior managers, the other executives, and that's why it has worked. But anyway, look, we need to.
Chair, can I just come in?
Oh yes,
if I could. I don't want to flatter us unnecessarily, but I think it's fair to say, and I take your point, Jane. It's teamwork. I think all my executive colleagues are fab. But looking at FIC, the nature and the detail within the reports are such it leaves little room for opacity, and you never want to be in that type of meeting and be needing to ask basic questions. We don't. We move to the more, I'd like to think, involved. With that in mind, just taking my cue from Abiola, I think the scale of the ask, I don't think it's clear, the scale of the ask, financial ask over the next 3 to 5 years, with respect, Oliver, is well beyond the current boundaries of service redesign. Moreover, it's well beyond any financial gain that is derived from flattening variation in performance, and indeed those productivity gains that we started to explore at the last committee meeting. And in my estimation, and this is my injunction to the board, unless and until we consider in a sober manner what that additional transformation may look like, we may be caught out.
Which we cannot afford to do, we wouldn't do. Okay. I mean, I wanted to go over a bit of time there because these matters are so important. You know, quality is really the most important thing, but we've got to get the finances right. You've got to work within your means. So thank you very much indeed. Nitin, please, the Audit Committee. Thank you very much, Anil.
Thanks, Chair. I will keep it really brief. I'll take the papers as read. The Audit Committee meeting was fairly uneventful, which is how we want it to be. In most cases, we got a usual report from internal audit. We discussed a board assurance framework, particularly governance. We had the external audit report, and the external audit plan is underway right now. We had an update from Usman talking about some of the financial stuff that we have been discussing here. And then we had a regular update from Information Governance and Security Subcommittee. Nothing to escalate to the board as such.
Thank you, Nitin. Okay, thanks very much indeed.
So just a very quick point. Anil, you asked earlier about the fraud and the compliance against it. In the report, it contains the compliance requirements and how we're responding, which is covered in the report. So if you have any further questions, I'm happy to pick it up outside. But it does talk about our compliance with new failure to prevent fraud legislation, and where the trust is within that and how we are progressing. Sorry, Nitin, I just
Thank you. That's great. Thanks very much. Sealed documents report.
Thank you, Chair. So this is a very straightforward sealed document report from the last time we recorded. It's been used once, and the details are captured in there for noting purposes and for this board's attention. Nothing more to report.
The corporate plan, I think it's just, updated.
Yeah, I think it's really important to acknowledge again the piece of work that has gone into it from the team's perspective, not only my team directly, but the others involved sitting on my right-hand side, great colleagues to work with to pull this all together from the planning aspect. I think the two things I would want to draw to the attention for this board for completeness, one, that going forward in 26-27, the Finance and Investment Committee will move to a different date, and the board will be aligned accordingly. So we have enough time between the Finance Committee and board meetings, so information flow will be better and improved. The second thing to note is the board assurance framework we just looked at within the reports, and the agreement with the board has been that it's going to move to the quarterly reporting for the entirety of the BAF. The BAF risk that the board holds, it will come to its every meeting as it comes to every other committee.
Good. Thank you very much. Any other business that has not been made aware of? Thank you very much. So we meet again on February the 5th. Thank you. Yes, happy Christmas. Thank you very much indeed. Thank you very much. Meeting closed.